Hello everyone, I'm Taz. I'm a fourth year student and I'll be talking about rheumatology today. This is my very first revision lecture and I literally prepared the slides this morning. So if there's any typo, we're not seeing that. Okay, so I have some contents here before we're covering. So whenever you want to revise in your own time, just go through it. Okay, we start with osteoarthritis, which is really common. It's defined as a breakdown of joint cartilage, and it might reach the underlying bone with inadequate repair. So risk factors for osteoarthritis are age, obesity, trauma, excessive joint use, female sex, family history, and hemophilia. Pathophysiology, it's caused by chronic mechanical stress on the joint, which leads to increased proteoglycans production, that leads to collagen turnover, decreased elasticity, which leads to degeneration of the cartilage, and then inflammation, synovitis, and then bone erosion and new bone formation, which leads to osteophyte formation. Symptoms of osteoarthritis will be mechanical joint pain, which is pain that is worse in the evening and it worsens with activity. It's asymmetric with more than 4 joints involved usually. Most common sites are weight-bearing joints and DIP. Less common to find it in PIP and MCP. We get morning stiffness that lasts less than 30 minutes because it's mechanical joint pain. We get joint instability and decreased range of motion and crepitation, and we don't have any systemic symptoms because it's not inflammatory. Signs, we have osteophytes. In DIP, they called Hibberdin's nodes, in PIP, Bouchard's, and in the thumb, it's called erythematosus. And we also have varus knee. Diagnosis from the symptoms and signs, but in lab work, we will find normal CRP and ESR. It's rheumatoid factor negative, and arthrocentesis will result in clear viscous fluid. Imaging, got X-ray, we find marginal osteophytes. We have narrowing of joint space. We have subchondral sclerosis and subchondral cysts. MRI will be finding cartilage loose and marrow lesions. Next, we have gout, which is inflammatory crystal disease. It's caused by deposition of monosodium urate crystals in the synovial fluid and soft tissue. Causes is hyperuricemia, which can be caused by decreased excretion by the kidneys or glycogen storage disease or overproduction of purines, which can happen with increased intake, which we find it in shellfish, red meats, and corn syrup. And we can also find in Leishmanian syndrome and other conditions that you can read about later. We can also find it in tumor lysis syndrome, which can happen with chemotherapy. Risk factors, it's male, diabetes, obesity, hypertension, dyslipidemia, alcohol, and genetics. It's also very common, so you'll find a lot. Pathophysiology is uric acid reduction that gets saturated and the extracellular fluid, giving us supersaturated extracellular fluid, and then intra-articular acid crystal deposition, which gets coated by antibodies. And then we get phagocytosis, release of cytokines, and then we get local inflammation, which is very painful. Triggers sudden increase in uric acid, which can happen in turnover. Trauma, surgery, diuresis, and dehydration. Symptoms, severe acute joint pain with overlying erythema. We get swollen warm joint, might have fever, might wake up from the pain because it's very severe. The peak pain is 12 to 24 hours post onset, and we can get desquamation of the overlying skin. Education, it's mostly monoarthritic during the first attack. While women are most likely to present with multiple joints. And it's often asymmetrical. Podagra is something you need to remember. It's your big toe, which is the most common site. Yeah, so between attacks, it's mostly asymptomatic. Chronic gout, it's progressive destruction and tophi formation. So you might see yellow or white because of the overlying skin, and you get renal issues. So in history, you'll get rapid onset severe pain, joint stiffness with the risk factors that we mentioned before, Examination, similar. So you got erythema, warmth, joint stiffness, tenderness, and sweating or effusion and tophi formation. So lab work, blood will get high, sometimes high white blood cells. We get increased ESR and CRP, serum uric acid elevated mostly, and you can do your ECs as well if you're asking an OSCE. Imaging with ultrasound, you can find a double couture sign with bone erosion and maybe tophi. Arthrocentesis, we get negative bifurcant needle-shaped crystals, double ones. So gout management, first line NSAIDs, we give low dose steroids for a short while, or we can give local steroid injections. Second line, colicine inhibits migration, reduce inflammation. Third line, which is for chronic, we give febuxetate. Complications, we can get uric acid nephropathy and nephrolithiasis. They don't have too bad of prognosis, but tophi can happen like in 10 years in half the people. Next is septic arthritis. It's inflammation of the synovial membrane with perfusion into the joint capsule due to the infection. So we got two mechanisms of infection. We got hematogenous spread or direct spread or trauma. So we have two types, gonococcal from Neisseria, which is very common in young people and with STIs. We have a non-gonococcal, so all the other pathogens are listed here. Risk factors, prosthetic implants, rheumatoid arthritis, IBD, joint disease, immunosuppression, diabetes, advanced age, chronic skin infection, or recent surgery. Pathophysiology, it's like macrophages release cytokines. We get vasodilation, we get inflammatory response, fluid accumulation to the joint space, increased pressure, compression of blood vessels, and then necrosis of the bone and cartilage. Symptoms, acute onset, we get erythema, swelling, warmth, pain, decreased mobility, increased temperature. With gonococcal, we get multiple joints affected with skin lesions sometimes. Non-gonococcal, usually one joint is affected, mostly the knee, and it's more severe, and it's mostly in elderly. Diagnosis, arthrocentesis, you will get cloudy synovial fluid with high white blood cells, mostly neutrophils. Imaging, you can find bone erosion and joint effusion. Bloods, you get inflammatory signs, increased ESR and CRP and leukocytes. Management, it's an emergency, so it's an urgent hospital referral. They get antibiotics depending on the causative organisms. So with gram-positive, we give vancomycin or fluoxetine. Gram-negative, we give Cef. Gram-negative bacilli, we give, I'm not gonna bother pronouncing this. And then we also have to manage the pain. So, and then serially dilate to find the effect of the antibiotics, like follow-up. Next, rheumatoid arthritis is also common. It's a chronic inflammatory condition. It affects synovial joints, and it can be systemic and affect other organs. So cause is autoimmune. Risk factors can be that can trigger infection, smoking, family history, or premenopausal females. Pathophysiology, ouch, I don't know what happened here. So some trigger affects the, modifies the articular proteins, and then self-antigens get attacked by autoimmune. We get rheumatoid factor or anti-CCP accumulation in the synovial fluid, which can activate the complement system, and then we get inflammation and injury. We get stimulation of synovial cells, which makes a pannus, and also breakdown of cartilage. Presentations, 3 or more joints are affected symmetrically. So common sites are PIP, MPG, and wrists. Other you can find it also in your neck or hip. More rare places are DIP and the first MPG. It's inflammatory joint pain. So we get morning stiffness that improves with the use and has to last for more than 6 weeks. Other symptoms that we might find are decreased grip strength, decreased range of motion, pain, and swelling. We can get in a flare or an acute attack, we get edema, erythema, and warmth and pain in the joint. So deformities, which are irreversible, unlike some of the other conditions, can happen late in unmanaged conditions. So in the hands, we get the swan neck, boutonniere, ulnar drift, or Z deformities. A lot of them we find in this picture. In the spine, we can find misalignment or destruction of the joints. In the feet, we get the cloud toes. It looks like a bird claw. So systemic symptoms. We can have in a lot of other systems, it affects almost everything. So in the brain, we get fever, fatigue, weight loss, anorexia. In the eye, uveitis, scleritis. In the skin, we get rheumatoid nodules, which are here. They're subcutaneous, firm, non-painful, and they're usually around affected joints. Musculoskeletal, we get carpal tunnel syndrome, tensinosynovitis, and bursitis. Vascular, we get a lot of vasculitis, Raynaud phenomenon, and purpura. In the heart, they can get heart attacks, strokes, which is the leading cause of mortality. They can get pericarditis or myocarditis as well. In the lung, they get PE, pulmonary fibrosis, and Kaplan syndrome, which is directly related to rheumatoid arthritis. Hematological, they get anemia, neutropenia, splenomegaly, lymphoma. And they get Sjogren's syndrome, which get like a dryness of the mucous membranes, and amyloidosis. Cool. Investigations, bloods, we get anemia, thrombocytosis, and leukocytosis, increased ESR and CRP. The autoantibodies, which is generally as a rule in rheumatology, like remember the antibodies, they're a big clue. So rheumatoid factor is not the most specific because only 70% might have it, and you can get rheumatoid factor in other conditions as well. Anti-CCP is the best one in rheumatoid arthritis, because 96% have it, and 10% will have ANA. So arthritis, you find it's to eliminate other causes like gout or septic arthritis. X-ray. You get osteopenia, you get soft tissue swelling around the joint, narrowing of the joint space, you get bone erosion, and some chondral cysts. So differentiate between this and osteoarthritis and X-rays. The swelling in osteoarthritis is literally bony, so it'd be hard, while rheumatoid arthritis is soft because it's swelling. MRI for cervical spine when it's affected, and ultrasound for synovitis. So the management, in acute attack, NSAIDs and steroids for less than 3 months. Long-term, first line is methotrexate plus another DMARDs and folate injection. Keep in mind methotrexate side effects. You can get it to pregnant women and whatever is listed here. And also it's renally excreted, so be careful, people with kidney disease. Second line biologicals can be monoclonal antibodies like adalimumab. Also in clinical remission, they still need some pain management that can be done with NSAIDs and fish oil. SLE, systemic autoimmune disease with multi-system involvement, which systemic means anyway. Cause is not unknown, but there are risk factors. So it's like family history, HLD, T2 or 3 genes, and classic complement pathway protein deficiency. Hormonal estrogen, it's more in females than males. Environment, smoking, UV, BB, viral infection, or some medications that can affect it. So why it happens? There is deficiency of the classic complement protein, which leads to failure of macrophage to phagocyte immune complexes and apoptotic cell material. We get dysregulated intolerant lymphocyte targeting, which is normally hidden, and then we get production of auto antibodies, specifically anti-double-stranded DNA. It's a type 3 hypersensitivity reaction. The antibody antigen complex formation happens in the vessels, leads to complement activation and tissue damage. Type 2 hypersensitivity happens, which leads to red cell lysis. So symptoms. So systemic symptoms, we get fever, malaise, weight loss, MSK symptoms, arthritis, arthralgia. We have distal symmetrical joint pain and myalgia. Skin, we get malar rash, Raynaud's phenomenon, photosensitivity, discoid rash. Here, your typical butterfly rash in the face. We got oral ulcers. We got non-scarring alopecia, hair loss, and telangiectasia. So heme, we get petechia, pallor infection, and anemia. We also get infection of the serous membranes. We get pleuritis, peritonitis, and pericarditis. In kidney, they can get nephritis. In the heart, we get all the carditis and other conditions. In the lung, we get pneumonitis, interstitial lung disease, pulmonary hypertension. We also get vasculitis, and neurological can be seizures, psychosis, some personality change. We got cerebritis, aseptic meningitis, and polyneuropathy. Diagnosis, it's a lot, I know. Diagnosis, so blood. Full blood count, we have anemia, leukopenia, and thrombocytopenia, which I already mentioned. We get increased inflammatory markers, CRP and ACR. Coagulation, we get prolonged PTT. And UEC, we get kidney manifestations. Autoantibodies for SLA, you need to remember. ANA is the most specific to lupus, but it also needs to be clinically matched with the symptoms. Anti-double-stranded DNA, it's also positive in 60 to 70% with the patients, and it's more correlated with the disease activity, isn't in an acute attack. Anti-Smith can happen in less than 30%, but it's highly specific. So if they have it, they're pretty likely to have SLE. Complement, because they have complement levels lower, they have low C3 and C4 or both. X-ray is for some of the serositis symptoms. We get pleural effusion, cardiomegaly. Management, lifestyle. So sun protection, stop smoking, cardiovascular risk, osteoporosis prevention, vitamin D. For cutaneous symptoms, steroid creams. For systemic symptoms, so first line is chloroquine. We also can give them alongside prednisolone or for short term or NSAIDs. Second line is methotrexate. Yeah, I already talked about some of the complications, though they have prognosis that's not too bad when it's well managed, though they have 90% 10-year survival survival rate, sorry. But they do have reduced overall life expectancy. AS, it's a chronic axial inflammation. So risk is with younger middle-aged men, and it's family linked with HLA-B27 gene. So it's not fully understood. It might be autoimmune against type 1 and 2 collagen, which leads to the destruction of articular cartilage. And then we get the fibrin deposits, and then the making of fibrous bands around the joints, and ossification, which leads to the making of syndesmosis. It's a type of joint. It includes some immune cells involvement and macrophages, and a lot of cytokines. So locations is mostly in the spine or sacroiliac joint. And symptoms and size. So in the spine, we get morning stiffness and back pain, lasts around 30 minutes in improvement, movement, inflammatory joint pain. At the sacroiliac joint, we get buttock pain and tenderness. We get reduced spinal mobility. We get inflammatory pain in some of our tendons. We get pain, dactylitis. We got kyphotic deformity on the back. Systemic symptoms can be weight loss, fever, fatigue, uveitis, tendinitis, shortness of breath, which can be due to impaired chest wall expansion. We also get restrictive lung diseases. Restrictive lung diseases due to pulmonary fibrosis. And we get arteritis, which is dilation of the aortic ring and increased, which leads to increased aortic insufficiency. Pretty multi-system. Diagnosis, most suggestive of AS, we get gradual onset before the age of 40. Duration of the symptoms longer than 3 months. We get prolonged morning stiffness and night pain. It improves with activity and exercise, and it fails to improve with rest. And it has pretty good response to NSAIDs. Investigations, we have imaging. We can find erosions, and we have bamboo sign. Genetics, it's Chile B27 gene. So management, lifestyle, exercise, stop smoking, physiotherapy. Pharmacology will be some NSAIDs and some DMARDs, and we can use some monoclonal antibodies like adalimumab. And in some cases, they might need some steroid injections into the joint. We also have to take care to monitor chest expansion. Polymyalgia, PMR, it's an inflammatory disorder that can cause widespread aching and stiffness and flu-like symptoms. Risk factors: above 50 years of age, female, North European ethnicity, and in 10 to 15% will have giant cell arthritis. Pathophysiology, it's unknown trigger and it's not fully understood. And we get periarticular and articular inflammation. We get some pain in the shoulders. So location: shoulder, neck, and pelvic girdle. Symptoms: systemic fever, weight loss, and night sweats. We get fatigue and malaise. We get depressed symptoms, anemia symptoms, and some musculoskeletal symptoms. We get morning stiffness, which lasts more than 45 minutes. New onset symmetric pain that's worse at night. We get muscular atrophy and weakness due to pain and stiffness, and we got giant cell arthritis in some of them. Investigations: full blood evaluation, it's variable. Some will have normochromic normocytic anemia with leukocytosis. Inflammatory markers are both increased, but ESR is increased more than 90. CK will be normal because we don't really have muscle atrophy. CCP and rheumatoid factor negative. Imaging, we get with ultrasound, bursitis, tenosynovitis, and synovitis and joint effusion. Management: so first line, prednisolone, they react pretty good with steroids. If symptoms does not improve with steroids, consider some other condition. Pain management otherwise with NSAIDs. So to reduce osteoporosis risk, we all have to give calcium and vitamin D supplements. Second line, which is treatment resistance, methotrexate, and then third line monoclonal antibodies. So when we're suspecting PMR, we have to wait for investigation results before starting the steroids, unless GCA is suspected, in which case we have to start it straight away. So GCA, giant cell arthritis. So it's vasculitis of the scalp, neck, and arm arteries. The risk is female of North Korean origin, age more than 50 years, genetic predisposition. Infection with parvovirus might be a precipitating factor, and 50% of them will have a PMR. Symptoms: new onset temporal unilateral headache. We get fatigue, we get pain during chewing and brushing the hair, which is very buzzy. We get jaw claudication and hard and tender temporal artery. It's a type 2 hypersensitivity reaction. We get autoantibodies. We get ANCA antibodies. And it can lead to local vascular damage and changes in the blood vessels composition. Giant cell arthritis, again, complications. They can get vision loss, which is a rheumatological emergency, because in 20 to 50%, they will lose their vision in the other eye within a week. It's caused by ophthalmic artery blockage in most people. So risk for vision loss: delayed diagnosis of GCA, normal inflammatory markers, thrombocytopenia, and permanent loss of vision and TIA. So again, 40 to 50% will have PMR. They can also get some large vessel arthritis, like in the aortic artery or its branches, and we can get aortic aneurysm, and it's more likely to be thoracic than abdominal. Management, again, steroids that we have to start before confirmation of the diagnosis. Confirmation of diagnosis happens through a biopsy. With visual loss, we have to give methylprednisolone. In the ischemic event, we give them aspirin. For some people, we consider methotrexate and giving plus folate injection in combination with the steroids, and consider giving calcium and vitamin D because of the steroids. Investigations is like examinations. You get absent temporal artery tenderness, abdominal fundoscopy, absent temporal artery pulse or Bruy on auscultation or neurological changes. Labs, increased inflammatory markers. We can get normocytic anemia, normochromic normocytic anemia, normal white blood cell count. We can get elevated platelets count. Iron studies, they have raised ferritin. LFTs, just mildly elevated liver markers. Coagulation is normal or elevated fibrinogen. Imaging, temporal artery ultrasound might show thickening, which is halocyaned, or stenosis or occlusion. This is not routinely done in Melbourne. They've been trialing it at MMC last year, I think. So the diagnostic is a biopsy of the temporal artery, but they also have skip lesions. So sometimes the result might come back negative. So we rely on clinical diagnosis a lot of the times and then repeat the biopsy again. So osteomyelitis, it's an infection of the bone. It can be caused by a spread or trauma from orthopedic surgery or contagious spread, people with diabetes, diabetic foot ulcers, or prosthetic joints. It's in the elderly, more likely they get vertebral infection caused by TB. In children, it's likely to have metaphysis as well, infection. So risk factors can be poor tissue perfusion, open fractures, severe tissue injury, immunocompromised individuals, diabetes, IV drug use, or previous osteomyelitis. Pathophysiology, acute phase, which happens within weeks. So we get bacterial invasion and into the bone necrosis, and then abscess formation. Chronic osteomyelitis can take months to years, which is like a late phase. It happens through inflammatory pathways. We get cytokine formation, which can lead to bone resorption, and then fibrous tissue replacement with bone. We get sequestration, which means that the necrotic part of the bone gets separated from the rest. It looks like an island. Both of them, abscess can spread to adjacent tissues, so we can get an inflammation that's spreading around. Symptoms in acute, it's gradual symptoms over days. We get pain at the infection site, tenderness, swelling, and redness. We get malaise, fever, and chills. With chronic osteomyelitis, its onset follows previous episode, and they get recurrent pain and weight loss. Management, antibodies depends on the affecting organism. So with low MRSA risk, we give flucloxacillin, and if they have penicillin allergy, we can give vancomycin. If it's high risk of MRSA, we go straight away into vancomycin. If we have epidural or vertebral abscess, which can lead to neurological symptoms, we give flucloxacillin, vancomycin, and KEF. They might need some surgical involvement as well in severe symptoms. Diagnosis with labs, we get increased inflammatory markers. We might need some wound swab if it's an open infection, or blood culture. We can do also LFTs, use CEs, glucose, or just to check for diabetes. Imaging, in an X-ray, we find some thickening of the cortical bones and periosteum. We get elevation of the periosteum. We lose the normal architecture of the bone. We get osteopenia with half of the matrix is lost. We get abscess, which we can see in bone scan MRI, and sequestrium in chronic osteomyelitis. Biopsy, it's needle guided, just so we can identify the pathogen and sensitivity and confirm the diagnosis. Scleroderma, we're almost closer to the end. It's an autoimmune condition that leads to systemic sclerosis in the skin that can involve some other organs and vessels. So risk is female sex, 30 to 50 years of age, and African American ethnicity. Etiology can be genetics, family linked, some viral infections, which can trigger it. Silica dust, some pains, vinyl chloride, some medications like cocaine use or bleomycin or benzocaine. Pathology, we get some endothelial injury, which can lead to non-inflammatory vasculitis. Some T-cell adhesion molecules happen, which releases cytokines, damages the blood vessels, activates the fibroblasts, which leads to fibrosis and ischemic tissue damage. B cells can be involved in releasing ANA, which can lead to cell damage. Antibodies, again, important to remember. We have ANA, anti-SCL70, like Scleroderma 70, which is a DNA isomerase 1 antibody. We have anti-RNA poly3, RA, and anti-centromeres. So with these antibodies, we have two types of scleroderma. We have the diffuse and limited, which I will talk about in the next slide. With the diffuse, we get anti-SCL70 and ARA, and with the limited, we get ACA. We also have to do some pulmonary function tests, and because it's a multi-system involvement, and ECG and chest X-ray and gastroscopy, barium swallow test, and B. So the only reason I included the management diagnosis here is because I have no space in the next slide, sorry. Management, we need rheumatology referral. We need use physiotherapy and use of moisturizers. We can consider using methotrexate again. They have GORD symptoms, we can treat it with PPIs, and Rheumatoid, we can treat it with CCBs or nitrates. They have poor prognosis. Their mean survival is 12 years after diagnosis. So the two types of scleroderma, we have the diffuse cutaneous scleroderma, which is the bad one. We get rapidly progressive symptoms, and it has a visceral involvement pretty early, like other organs involvement. Symptoms and signs, they start with the fingers and then they go up. So we start with swollen, puffy hands. We start with a sclerodactyl, which is tight, stiff, and shiny, smooth hands. And mouth, we get small mouth, microstomia. Nose, we get big nose. We get calcium deposit, calcinosis cutis. We get Raynaud's phenomenon. We get ulceration on the digits caused by ischemia. We get telangiectasia. We get in joints, we get pain, stiffness, and restricted mobility. And in the GI tract, we get esophageal dysmotility, which can lead to incompetent lower sphincter, lead to GORD. We also get strictures, which leads to malabsorption and anemia. In the lungs, we get pulmonary artery hypertension and pulmonary fibrosis, which can lead to right heart failure. In kidney, we get scleroderma renal crisis. Limited cutaneous systemic scleroderma, also known as CREST syndrome. It doesn't have that much signs of internal organ involvement at the start. So symptoms are calcinosis cutis, Raynaud phenomenon, esophageal dysmotility, sclerodactyl, and telangiectasia. And the skin involvement in CREST syndrome is limited to the face and hands mostly. Cool. ANCA-vasculitis. We have 3 of those. So Wagner's, also known as granulomatosis with polyangiitis. It's a small vessel vasculitis. It's involved in the upper respiratory system, lower, and kidneys. So symptoms of the upper respiratory tract, we get saddle nose deformity, chronic sinusitis, otitis media, mastocytitis, and perforation of the nasal symptoms. Lower respiratory tract, we get hemoptysis, dyspnea, and in an X-ray, we can find cavitating lung nodules. Kidneys, we get hematuria, we have crescenting rapidly. we get progressive GTN, and in urinalysis, we can see red blood cell cast. Investigations other than what I mentioned already, we get ANCA and biopsy non-cascading granulomas. So management in an attack, we induce remission with 3 ways. So it's either steroids or steroids with some other medications like a DMARD or monoclonal antibody. Vaccinations, because of their high risk of severe disease. We get screening of complication of steroids like Cushing syndrome. We teach them nasal hygiene measures, and we have to maintain remission by a rheumatologist. So prognosis, they have 5-year survival rate, which is not bad. Other vasculitis, we have P-ANCA vasculitis. We have microscopic polyangiitis, which is exactly the same as GPA, except they don't have any upper respiratory symptoms. Cause can be with medications, especially penicillin. Serology, they get P-ANCA and they don't have any granuloma. And management is the same with all of them. So EPA, it has 3 phases. Phase 1, we get our atopic symptoms like allergic rhinitis, sinusitis, or adult onset asthma, which all have high IgE. Phase 2, we get tissue infiltration by eosinophils. Phase 3, we get vasculitis and inflammation of the organ system. And yeah, I already mentioned this. Symptoms, we get severe asthma attacks, which is normally what's presenting them in the first place. We get skin nodules, purpura, impaired mental state, mononeuritis multiplex, which is rest or food drop, pericarditis, or gastrointestinal involvement. Investigations, chest x-ray, we get transient migratory pulmonary infiltrate, blood eosinophilia, and increased IgE and P-ANCA. A biopsy, we get tissue eosinophilia and necrotizing granulomas. Cool, that was all the conditions. That was pretty quick, I think. I have a lot of questions. I've added the PDF to the drive that has past exam questions, and I have questions here from a question bank, so I can share that with you. Let's go. Can I see the chat here? Okay, where want to go? So 40-year-old mechanic presents with joint pain. For the past 2 months, noticed intermittent joint pain, stiffness, swelling of the joints in the hands and feet. The stiffness tend to improve during the day, but the pain get worse. He noticed stiffness in his back, but can't really remember any injury. Blood tests show negative rheumatoid factor, anti-CCP positive, uric acid is normal, ESR is slightly increased. Okay, anyone want to make a guess? Anybody? Okay, answer is rheumatoid arthritis. Because rheumatoid factor, again, is not specific for everybody, but anti-CCP is pretty much pretty good indicator. So that's next. Yep, that's next. So 28-year-old with SLE that's well controlled. She reports that she and her partner are planning to become pregnant. So which of the following medications would be safe for this patient to continue? So these are DMARDs and biologics. I feel that this is an unfair question, to be honest. So I'll give you the answer. Yeah, a lot of them are teratogenic that aren't safe to use in pregnancy because they can cross the placenta. Cool, next. 27-year-old goes to the ED with fever, severe pain in the knee. An examination, the right knee, swollen and red. There is reduced range of motion in both flexion and extension. The joint is warm to touch. Heart rate is 92, rest rate is 19, blood pressure is normal, temperature is 39.1. No past medical history, no regular medications, live with his girlfriend, and he is sexually active. So what do you guys think is the diagnosis in here? Anyone want to shout out the diagnosis? C, correct, because he is young, septic arthritis, so gonorrhea, most likely in young people. Cool. 27, 3-month history of back pain, and in women, the pain is worse in the morning. It's associated with stiffness. Symptoms can improve throughout the day with physical activity. It's predominantly in the right lumbar spine, and the patient has been finding it difficult to carry daily tasks. He suspects an AS. So which of these symptoms would be most likely to confirm the diagnosis? It's getting louder. Anyone want to shout out an answer? Yep, C again. Cool. It's inflammatory pain. Okay, next, 25-year-old goes to rheumatology clinic, diagnosed with SLE. Symptoms are mild, and we plan to start monotherapy with hydroxychloroquine. So, think about the side effects. So, which is recommended monitoring that we have to do with hydroxychloroquine? Anyone want to shout out an answer? Yeah, it's E. Cool. Severe retinopathy. 78-year-old man presents to GP, severe headache, jaw pain for the past 2 weeks. Describes the headache as constant and throbbing, affecting his right temple. It's worse on chewing, talking, and when he's climbing stairs. He reports fatigue, low-grade fever, and muscle stiffness in his upper and lower limbs, which are worse at night. He doesn't have morning stiffness. He doesn't have visual changes or tinnitus, and no history of trauma. It's very buzzy. Anybody? C again. I don't know why they're all C. Yeah, GCA. Cool. Next, 33 female presents pain and stiffness in the right knee, unilateral. She had for the past 3 months. She had pain and stiffness in her left wrist as well, in the distal interphalangeal joint, DIP, of the index finger. Symptoms worse in the morning and seem to improve throughout the day. Her late mother also had similar problems, but she doesn't know what the diagnosis was. Okay, most likely diagnosis. B, cool, psoriatic arthritis. I actually forgot to add this to the slides, nice. Good job. 40-year-old man presents to the ED with chills, nausea, painful and swollen left elbow, which been getting worse for the past 24 hours. So 5 days ago, he injured his forearm during a rugby game. No significant past medical history. Observations, all normal. Examination, left elbow is swollen. It's erythematosus, warm and tender to touch. There is a graze on the anterior forearm with surrounding swelling and erythema, with some purulent exudate on the edges. So what is the most important investigation? What do we think is the diagnosis? Our top differential. Yeah. Septic arthritis, we need synovial fluid analysis. Cool. 36 women goes to the GP from a headache on the left side of her head that's throbbing. She had these headache attacks on and off for the past 2 weeks. The headache is made worse when doing her daily walk to work in the morning, and recently she had to take some days off work because of it. She also describes visual disturbances such as flashing lights and general discomfort with bright lights. She has past medical history of eczema and she doesn't take any medications. Shout out again? Yeah, it's migraine. Because GCA wouldn't be in people under 60. It's rare. Cool. So 25 women presents with a weak history of fatigue, fever, sharp right-sided chest pain, which is worse on inspiration. She complains of intermittent joint pain in her hands, which has been present for around 4 months. Examinations show erythema over her cheeks. So, most sensitive for this condition. What condition are we thinking of? Sorry, which condition? Yeah, it's SLE. So what do you think? Which one of these? ANA, right. So, pleuritic chest pain, probably from sinusitis. So give us SLE. Cool. 74-year-old woman, polymyalgia, after complaining of a 2-week history of proximal muscle pain and stiffness with increased inflammatory markers. Which of these medications consider a different diagnosis? Yep, prednisolone, because it's pretty sensitive and effective. Cool. I have some more questions because we have time. Cool. Give me a second. I uploaded it to the drive now on my laptop. Okay, these are past exam questions. And feel free to read and shout out the answer. Mechanical joint pain. Sorry? Yeah, osteoarthritis. Easy. Good. So, knee swollen, Right tibia moves anteriorly when pulled forward, the drawer test. His knee is bent at 90 degrees compared to the left. Some sort of injury. Yep, ACL rupture. Cool. Whenever you want me to stop. Cool. Meningococcal meningitis. She had IV antibiotics. Next day, she has hot and swollen left knee. Aspiration of the knee showed cloudy fluid. No crystals. Straightforward. Yes. Say it out loud. Shout. Ah, yeah. Septic arthritis. Cool. I think we've done this one already. 10%. Yeah, we've done this one. Okay, this 70-year-old man, 6 weeks of fatigue, increasing pain, with early morning stiffness in both hips and shoulder. He requires assistance to get out of bed in the morning. ESR is increased. He has ANA negative and rheumatoid factor negative. Any guesses? PMR. Cool. Next. Let me know when you get too tired. I have a lot of these. Oh, and I have the answer. Nice. So, inflammation, worm, tender joint, septic arthritis. Cool. Next, 61-year-old man, acute pain in his foot. It has tenderness, it's swelling, and erythema over the ankle joint. There are some whitish deposits over the distal interphalangeal joint of the second and third and fourth digit of both hands. So, which marker are we likely to find? Oh, I think they want which investigation do we need? Yeah. Yeah, it's gout. Cool. Next, 27-year-old woman. She had generalized pain, lethargy, weight loss over 3 weeks. Examination shows swelling and tenderness of the wrist, metacarpal phalangeal and proximal interphalangeal, both hands. She has rash on her cheeks, necks, and upper chest. Looks lupusy to me. So ANA and anti-double-stranded DNA antibodies. Probably the last one, or before last. 68-year-old woman shows to ED with pain in her shoulders. She has difficulty hanging out her washings. She lives home alone. She struggles to cope. Aside from fatigue, she denies any other symptoms. Her blood tests are unremarkable aside from increased ESR. Yep, PMR. Cool. Next. Question. 72-year-old female, acute admission due to pain and swelling of the right foot, which got worse over the last 3 days. The foot is painful, unable to bear any weight on the foot. She has past history of hypertension. She get thiazide for. She has beta blockers, aspirin, treated with diet alone for type 2 diabetes. Very gouty, acute gout. Okay, good job, guys.